Bismillah ar-Rahman ar-Rahim. Welcome back to the second part of Bradyarrhymias. We will handle heart block. Heart block occurs due to disease of the AV node. It may present as a first, second, or third degree. And it may be congenital or acquired regarding its etiology. First degree heart block, it's not a real block, it's just a delay of transmission of the impulse from the atrium to the ventricle. So every sinus impulse reaches the ventricle but with a delay. This is an example of an ECG presentation of first degree heart block where you can find the very prolonged BR interval. Second degree heart block, it's an occasional non-conducted P wave. Not every P wave reaches the ventricle, but still there are many impulses that reaches the ventricle normally. It has two types, Mobitz type 1, or it's also called Wenckbach, or Mobitz type 2. Mobitz type 1 occurs when there is a progressive lengthening of the PR until a normally occurring P wave is not followed by a QRS complex. What I mean by a normally occurring P wave, that it arrives just in its appropriate time, not a premature P wave. And this results in a pause, which is maybe a rather short pause. To differentiate this pause, as it is due to complete heart block, we can notice that it begins with a P wave, not a QRS complex like the case of sick sinus syndrome. So when you see an ECG with a pause, look at the beginning of this pause. If it starts with a P wave, so it is a pause due to AV block. If it starts by a QRS complex, it is due to sinus node dysfunction. Any pattern of block can occur: 2 to 1, 3 to 2, or 4 to 3. In Mobitz type 2, no change in the PR interval before or after the non-conducted P wave, and also the P wave should arrive in its appropriate time, and the PR is always constant. Complete heart block, there is complete dissociation between the atria and the ventricles. A complete failure of AV node to conduct any impulse from the atrium to the ventricle. No sinus rhythm or no sinus impulse whatsoever can reach the ventricle. If there is no subsidiary pacemaker come to work at this moment, the asystole may occur up to death. Usually a subsidiary pacemaker takes over, which is maybe in the AV node or in the ventricle, what we call idioventricular rhythm. I will come back to the ECG of complete heart block. As you see, the BP interval, I mean the interval between each two P waves, is constant as it is coming from the SA node, and usually the RR interval, which is the interval between the QRS complexes, also is constant according to the type of pacemaker. It may be just slow if the escape rhythm is from the AV node, or it may be very slow and wide if the escape rhythm is coming from the ventricles. What is completely corrupted and unstable and unconstant is the relation between the P wave and the QRS complex, because every part of the heart, I mean the atria and the ventricles, are working separately from the electrical point of view. Now, what is the etiology of heart block? As we said, it may be acquired or congenital. Acquired due to increased vagal tone, fibrosis and sclerosis of the conduction system, ischemic heart disease, cardiomyopathies and myocarditis, congenital heart diseases, familial AV block, progressive cardiac conduction system disease, and others as electrolytes abnormality. A very important category is seen nowadays is the iatrogenic type of heart block, with increasing cardiac procedures done either percutaneously or surgery. AV node may be affected iatrogenically in many cases. Drugs also may cause heart block, like beta blockers, calcium channel blockers, digoxin, adenosine, antiarrhythmic drugs, different antiarrhythmic drugs, cardiac surgery, transcatheter aortic valve implantation, catheter ablation of arrhythmias, transcatheter closure of VSD, and alcohol septal ablation in hypertrophic cardiomyopathy. Now this is another example of AV block with failure of a subsidiary pacemaker to take over for a while, resulting in a prolonged pause. The tracings are continuous, as you see. The first complexes on the left are normally conducted sinus beats, then PBP without QRS complexes. This is heart block, resulting in a very long pause. The pause is ended by an idioventricular beat, which is the first beat in the second root tracing, and it is followed by spontaneous recovery of the AV node and normally conducted beat. Regarding the clinical presentation of patients with heart block, first degree heart block is usually asymptomatic. However, it may be symptomatic in the form of dyspnea or fatigue. Mobitz type 1 heart block may be asymptomatic in different cases, or in many cases, and it is usually may be physiological. We may find it normally in athletes. Mobitz type 2 and complete heart block are usually symptomatic, and they usually results from real AV nodal disease. Symptoms like symptoms of sick sinus syndrome, any symptom of cardiac patient may present, and the syncope is very, very frequent and very important. Syncope is usually occurs due to prolonged pauses, not followed by rapid presentation of subsidiary pacemaker, leading what is called Stokes-Adams attacks. These attacks may also occur due to tachycardia in this context of heart block. I will explain this point in the face-to-face session. And this is an example of heart block with inducing arrhythmia, ventricular tachycardia, leading to Stokes-Adams attacks, and we will explain further. Those are William Stokes and Robert Adams. Who loves history again can find this interesting. And this is the algorithm for the treatment approach to the patient with complete heart block. If you have an ECG with complete heart block, you should look at the patient if he is stable or unstable. If he is stable, you will refer for transcutaneous pacing or transient pacemaker, transvenous pacing, and do evaluation for reversible causes. If there is a reversible cause, you should treat the cause appropriately. If complete heart block resolves, so no further management. If not resolving, so you will go for cardiac pacemakers. During evaluation, if you didn't find a cause, you will go directly to permanent pacemaker implantation. And in your case, the general practitioner, you will refer for pacemaker implantation. On the other side, if the patient is unstable, you will give him atropine. If he is stabilized, you will go to the track of the stable patients for transcutaneous pacing or transvenous pacing. If after atropine he remains unstable, so you will go for transcutaneous pacing and rapid permanent pacemaker implantation. If until you arrange for pacemaker implantation, the patient remains unstable and he had low blood pressure, you can give dopamine intravenous. If he had heart failure, so dobutamine intravenous may help. If normal blood pressure and normal heart failure, you go directly to transvenous temporary pacemaker until the permanent pacemaker is implanted. These are the pictures of the transcutaneous pacemaker. On the left, it's pads like the ECG electrodes and connected with the pacer. It is rather unstable, so if the patient is unstable, it's preferable to do the transvenous pacemakers, and its picture is shown. This is the electrode or the lead which goes through the femoral vein or another vein to the right ventricle, and this is the battery which temporarily paces the patient until the permanent pacemaker is implanted. Another algorithm for pacing in AV block. And these are the guidelines for pacemaker implantation, permanent pacemaker implantation in patients with complete heart block, for further discussion in the face-to-face session. And please study these ECGs before coming next Wednesday. And thank you.